Important safety information for Aggrastat, tirofiban hydrochloride injection. Indication: Aggrastat is indicated to reduce the rate of thrombotic cardiovascular events, defined as combined endpoint of death, myocardial infarction, or refractory ischemia, repeat cardiac procedure in patients with non-ST elevation acute coronary syndrome. Contraindications of Aggrastat include a known hypersensitivity to any component of Aggrastat, a history of thrombocytopenia with prior exposure to Aggrastat, those with active internal bleeding or a history of bleeding diathesis, major surgical procedure, or severe physical trauma within the previous month. Warnings and precautions. Aggrastat can cause serious bleeding. Most bleeding associated with Aggrastat occurs at the arterial access site for cardiac catheterization. Minimize the use of traumatic or potentially traumatic procedures, such as arterial and venous punctures, intramuscular injections, nasotracheal intubations, etc. Concomitant use of fibrinolytics, anticoagulants, and antiplatelet drugs increases the risk of bleeding. If bleeding cannot be controlled, discontinue Aggrastat. Thrombocytopenia, discontinue Aggrastat and heparin. Bleeding is the most commonly reported adverse reaction. For additional information about Aggrastat, please refer to the full prescribing information. You are encouraged to report negative side effects of prescription drugs to the FDA. Visit www.fda.gov/medwatch or call 1-800-FDA-1088.
Hi, everyone. My name is Barry Bertolet. I'm an interventional cardiologist with Cardiology Associates of North Mississippi in Tupelo, Mississippi. I'm also the cath lab director at our institution and recently been elected the ACC governor for Mississippi. I'm here to present a case using Aggrastat for an ACS patient that was not adequately preloaded with oral antiplatelet medication. The purpose of this video is to demonstrate the typical use of Aggrastat for fellows as well as those cardiologists who may not be familiar with contemporary use of 2B3A inhibitors. My disclosures are that I am receiving financial support from Medicure for the creation of this video. Here's our patient presentation. I have a 56-year-old female who has advanced COPD, who has a history of a stent placement within the right coronary artery and has a known 50% stenosis of the LAD. She presented to the emergency department with acute respiratory distress. She did require urgent intubation and mechanical ventilation. Her EKG done shortly thereafter was remarkable for inferior ischemia, which prompted an urgent cardiac catheterization. Here's what we saw on the angiography. The cath revealed a normal left main and left circumflex artery. The proximal LAD still had that 50% stenosis. The right coronary artery was a dominant vessel and had a 95% mid-right coronary artery in-stent stenosis that was associated with thrombus formation. And then when you look at the downstream blood vessels, you can see an abrupt cutoff right after the PDA, and there is slow flow within the PDA itself, suggesting distal embolization. Before describing the next steps of this case, I want to point out that the problem with oral P2Y12 inhibition is that they take several hours to reach therapeutic levels of platelet inhibition, even when you're using ticagrelor or prasugrel. This is the pharmacodynamic data from 24 high-risk ACS patients undergoing PCI. Aggrastat, or tirofiban hydrochloride, is a reversal antagonist of fibrinogen that binds the glycoprotein 2B3A receptor, where it blocks the final common pathway to platelet aggregation. Aggrastat has a 2-hour half-life, and platelets return to normal function within 4 to 8 hours after you stop the infusion. So Aggrastat provides very potent and rapid platelet inhibition. With 96% of the platelets being inhibited at 10 minutes, Aggrastat has a very consistent response for patients, with 73% of patients reaching greater than 95% platelet inhibition at that 10-minute mark. The ACC, AHA, and SCI guidelines provide a Class 1A recommendation for glycoprotein 2B3A inhibition for non-ST elevation acute coronary syndrome patients who are undergoing PCI, but those that are not adequately preloaded with clopidogrel or ticagrelor. So back to our case. So this is how we decided to proceed. Because the patient was intubated and could not immediately take any oral medications, we initiated an Aggrastat IV bolus of 25 mics per kilo and an infusion of 0.15 mics per kilo per minute. Balloon angioplasty alone was done in the right coronary artery, restoring TIMI-3 flow. The Aggrastat infusion was then continued for 3 hours after adequate oral antiplatelet therapy could be initiated via NG tube to allow for this oral therapy to take effect. So here's some of the takeaways from this case. 1, Aggrastat IV bolus and infusion allows for a rapid and potent antiplatelet action in a situation where no or inadequate platelet therapy exists. So Aggrastat IV infusion time can be modified to allow transitioning to oral antiplatelet therapies based on the patient's ability to take oral meds at the time of the intervention. Thanks for watching this video, and if you have any questions, please reach out to your Aggrastat team for more information.